Good afternoon, everyone. I'm Rebecca Hubbard. I'm a professor of biostatistics at the University of Pennsylvania, and I'm very honored to be presenting the Gertrude M. Cox Lecture. I'm going to talk with you this afternoon about my research on using electronic health records to study human health and disease. And I'm going to focus in particular on how the complex data provenance that gives rise to these data leads to data quality issues that have implications for the validity and quality of our research, as well as the fairness of the research results that we produce. This is a topic that I've been working on for many years, and for many years when I would talk with people about data quality issues, their eyes would sort of glaze over, and I could see that this was maybe not the sexiest topic that they had ever heard of. I used to work for Kaiser Permanente Washington in Seattle, and working inside of an integrated healthcare system, I got a lot of hands-on experience seeing the way the data were generated, the messy form that they take, and generally their complexities. And I knew there were a lot of opportunities to do research with this data and to advance our research. But I also knew that there were big challenges in using these data in meaningful ways. Nonetheless, people were very excited about the potentials for research with EHR, and this particularly came to the forefront during the COVID-19 pandemic. So during the pandemic, when doctors found themselves faced with an urgent medical crisis which required immediate attention and for which clinical trials were ongoing, but they did not have the research results yet, they really didn't know when a patient would present in the emergency room with COVID, which treatment should they be receiving. People became very excited about the possibilities of using EHR data to advance the evidence base more rapidly than we could do with clinical trials. So on this slide, I have the headline of an editorial that appeared in Forbes touting the role that big data was going to play in helping us to address this urgent public health crisis. So all of a sudden, this research topic, which had been not so sexy, came very much to the forefront because people wanted to use these data. They wanted to do rigorous research in a way that could possibly even supplant clinical trials. And in order to do that, we need to have the highest quality evidence base. So all of the issues that I had been thinking about for many years suddenly became very vital and urgent. I'm going to tell you about that research, and I hope that as I do so, you can see how it connects with the things that Gertrude Cox was passionate about. Three particular ways that I've thought about. Firstly, are that my research focuses on advancing medical and public health decision-making and conducting research in that sphere, advancing it using modern data sources. So taking that topic and sort of moving it into the 21st century. Dr. Cox was also passionate about issues of study design, and I hope that I'll be able to illustrate for you how the work that I do connects with appropriate study designs for data that are created in non-traditional ways. And then finally, I want to touch on issues of equity and how we can make sure that everyone is a full participant in the research results that we're generating with their data. I'm going to start off by talking about EHR data provenance, which I'm going to use broadly to describe the complex process by which EHR data come to exist. On this slide, I have a figure from Google Labs, which illustrates the process of a single patient interacting with the healthcare system. This patient is followed in the record over time, and at various irregular points in time, they have encounters. Those encounters take different forms, so sometimes they make a primary care visit, later in time they have a hospitalization, and at each encounter, which I think of as the patient touching the healthcare system, different data elements are recorded. So early in this patient's record, they have a primary care visit, and their hemoglobin A1C is assessed. During this hospitalization, later in time, their creatinine is measured. Across all of these visits, we have medications being prescribed, different procedures are performed, diagnosis codes are recorded. So we could take this data and we could make it into a research database that's going to look like a longitudinal observational database. So we'll have repeated measures for a given individual. But the timing of the data collection is going to be very irregular because the spacing of those encounters is quite irregular. And we're going to have what appears to be a lot of missing data because many of these pieces of information are not recorded at all visits. So we might have hemoglobin A1C at only one visit. We might have creatinine at 5 or 6 visits. So we're going to have this very sparse and heterogeneous data set characterized by irregular observation and large amounts of missing data. This is just data from one patient. So if we took this patient's data and we combined it with all of the other patients who are part of our healthcare system, we would have a big longitudinal observational database. Superficially, it would look much like any other longitudinal observational study, except unlike data from a research study, the frequency of the visits and which data elements are recorded at each visit, and indeed even how those data elements are defined, is outside of the control of the researcher. So we haven't been able to specify anything about this visit process or anything about how the variables are specifically defined in order to make them appropriate to the type of research question that we're trying to answer. Even more challengingly, many of the statistical methods that we would use in that type of longitudinal observational setting assume that the visit process is non-informative. In other words, we assume independence of the visit process and the underlying disease process that we're trying to study. And when you think about healthcare data, that's exactly the reverse of what's going to be the case, because it's the underlying health process that's driving the visit process. So there's going to be a direct connection between the health of the patient and the frequency with which they're observed and the types of data elements that are recorded. So statistical methods that rely on an assumption of non-informative visit processes are generally going to be inappropriate and potentially lead to biased results. There are many sources of bias in EHR-based research, and in general, I like to categorize them as those that I would define as information bias and those that I would consider to be confounding. Information bias arises from all of the messiness and the imperfections and the lack of rigorous specification of the data that come from EHR. There's selection bias in who's represented in the EHR. There's measurement error and misclassification. As I described on the previous slide, tons of missing data. Many of the data elements that we will be able to extract lack harmonized definitions. And by that I mean across different healthcare systems and even across providers within a single healthcare system, they may not use the same words or the same codes in the same way. So it might superficially appear that we have information relating to the same medical condition from multiple different healthcare systems, but the precise way that that's been defined is inconsistent, leading to error and bias. On the other side of this slide, I have described a bunch of the sources of confounding. So confounding comes up often in EHR-based studies because typically there are characteristics that inform which treatments a patient receives, and often those same characteristics inform the outcomes that the patient experiences. And unfortunately, many of the most important confounders that we might be interested in have very limited information available. So things like behavioral risk factors, like smoking, drinking, exercise, and social determinants of health, describing the environment that a patient is experiencing outside of the medical system, tend to be pretty poorly captured. There's increasing interest in using narrative text notes to try to extract additional information. So perhaps a physician or a nurse recorded a note that describes, say, a patient's exercise regimen. But it's difficult to extract that information. Even when we do, there's going to be residual error in what's been extracted. And I think most importantly, it's inconsistently collected across patients. So the mere fact that a physician took the time to make that note is potentially confounded because it tells us something about the patient and the provider's interaction and their relationship. There are many pieces of information on potential confounders that could be available in the EHR but are inconsistently recorded. Things like family history of disease, for which there are sometimes discrete codes available, but those codes tend to not be frequently used because they are not required for treatment of the patient or reimbursement. And then often the most important confounders relate to the severity of disease, and those are frequently lacking. All of these things can be summarized just by saying that data not collected for research purposes may not be research quality. Our data elements aren't defined in the rigorous way that we wish they were. They aren't collected in the uniform and harmonious way that we wish they were. And the key confounders that we need in order to make the inference that we'd like to be making are not available because they aren't collected. So I'm going to focus on just one example of a problem that arises in the analysis of EHR data due to the complexities of EHR data provenance, and that's the challenge of phenotyping. Phenotype means the collection of characteristics that describe a patient. In other words, we're trying to characterize some aspect of the patient that is represented in the data. There's a lot of research in the EHR literature on phenotyping, and the fact there's so much of a focus on this topic is motivated by the fact that we basically lack gold standard information for many, if not most, of the characteristics that we're interested in when conducting EHR-based research. And that comes back to this concept that nothing is rigorously and harmoniously defined. So if we have a specific research quality variable that we wish we had describing a patient, we're going to have to try to match the EHR data up with that characteristic in some way and extract that information, perhaps from a combination of multiple different pieces of information that appear in the EHR. One of the challenges that arises in this process is the complexity of EHR data provenance. So that complex data provenance process that I've been describing means that we have heterogeneous information available across patients. So sometimes the key piece of information that we wish we had to come up with this phenotype is available, but only for some patients. And sometimes the availability of that information is itself informative. There, as I said, is a large literature on EHR-based phenotyping. The traditional approach is what's called rule-based phenotyping or decision rules, and that's just based on the clinical knowledge of the phenotype and its coding practices. So for instance, we could come up with a very simple phenotype for a disease of interest, which just says we're going to look at the patient's EHR, and if we see the diagnosis code for that condition, we're going to assume that the patient has the condition, and if we don't see it, we're not going to treat them as having the condition. So that would be the simplest possible phenotype. As I'm going to talk about on the next slide, there are a lot of limitations to using that kind of really simple phenotype. One of the limitations is that diagnosis codes in EHR are often nonspecific and erroneous. They often don't correspond in the way that we wish they did to whether or not the patient actually has the disease that we're studying. So in many cases, we don't just want to look for the diagnosis code, but we want to look for additional characteristics that corroborate that diagnosis. For instance, we might say we're going to look for the diagnosis code and we're going to look for a procedure or a medication that's frequently used to treat that diagnosis. Sometimes we'll additionally incorporate a time component, so maybe those codes have to appear within some temporal proximity to each other, or maybe we want to look for a chronic condition, so we're requiring that multiple codes occur over some period of time. This is an example of a clinical decision rule for type 2 diabetes, and it comes from a group called the eMERGE Consortium. So the eMERGE Consortium has put together a large database of phenotypes based on electronic health records from a group of healthcare systems that participated in a consortium. This type 2 diabetes decision rule works like this. So we start out up here in the upper left and we look at a patient's records. And the first thing we ask is, does the record indicate that the patient has type 1 diabetes? If they have a type 1 diabetes diagnosis code, then they're immediately kicked out of the algorithm and we assume that they do not have type 2 diabetes. If no, they do not have a type 1 diabetes diagnosis code, then they continue to the next node. We look for a type 2 diabetes diagnosis code. If no, then we go this way. If yes, then we go this way. And we follow the patient all the way down through the chart. And if they make it to the bottom, to this type 2 diabetes case node, that means they had the necessary combination of data elements to indicate that they had the condition of interest. If you look at the nodes that appear in this figure, they make a lot of sense as pieces of information that we might look for in order to make a determination as to whether or not someone has type 2 diabetes. So for instance, we look for diagnosis codes. We look for treatment with medications that are frequently used to treat type 2 diabetes. And we additionally look at the patient's biomarkers, specifically glucose and hemoglobin A1C, as potential markers of disease. And in fact, if we were conducting a research study and we had the patient in front of us, we would almost certainly make the classification as to whether or not the patient has type 2 diabetes by doing this biomarker test, either testing their glucose or the hemoglobin A1C and seeing if it falls in an abnormal range. So this algorithm is, in essence, a way of trying to deal with the fact that we don't have that biomarker information available for everyone. This algorithm was validated and had good operating characteristics in the healthcare systems where it was tested, but it has a number of limitations from a data provenance perspective. I think this is most clearly illustrated by considering two patients, neither of which is classified as having type 2 diabetes, but who have very different depths of information. So for instance, if we have a patient who has been part of our healthcare system for many years, has a number of records, they've made many visits, their glucose and hemoglobin A1C have been tested on multiple occasions and always fell in the normal range. That patient, if we apply this algorithm, we would come to the conclusion that we will classify them as not having type 2 diabetes. On the other hand, if we have a patient who made one ever encounter with their healthcare system, they fell off of their bike, and so their interaction with the healthcare system is about their twisted ankle, and they never had their hemoglobin A1C or glucose assessed, and they had absolutely no interaction with a medical provider that had anything to do with type 2 diabetes, that patient also would be classified as not having type 2 diabetes. But the certainty with which we've been able to assign those two classifications, which in this setting where we're just making a simple dichotomous classification, is completely obscured. The fact that we're pretty sure the one patient does not have type 2 diabetes and the other patient, we don't really know because they were never really assessed with respect to any of the key pieces of information that we need in order to make that determination, is completely obscured by just making this dichotomous classification. So back in 2019, I worked on a project where we developed an alternative approach, which was a Bayesian latent class model for EHR-based phenotyping. And the idea behind this Bayesian phenotyping model was to consider the phenotype as an unobserved characteristic, a latent characteristic which is fundamentally unobservable in EHR for all patients. So we consider the EHR to be, in essence, an imperfect reflection, a sort of reflection at one remove from the true health status of the patient. In my notation, I'm going to denote that true underlying phenotype as Y. And for patient I assume that that phenotype arises from a Bernoulli distribution with parameter theta I. So each individual patient has their own patient-specific probability of having the phenotype of interest. Y is completely unobserved for all patients, but what we do observe is a series of features which are present in the EHR. So those features represent things like diagnosis codes, procedure codes, medication prescriptions, and biomarker values. And here, all of those features, I'm assuming, just arise from some distribution, generically denoted D, where the parameters of that distribution differ depending on the underlying true phenotype status of the patient. So for instance, if we're talking about a diagnosis code, the probability that a patient has that diagnosis code in their record would differ between patients with and without the underlying phenotype. Or if the feature that we're talking about is a continuous biomarker, we might assume a shift in the mean or a shift in the variance associated with having the phenotype compared to not having the phenotype. Additionally, in order to account for this data provenance feature of the data, we assume that missingness is also informative with respect to the underlying phenotype. So here I let R denote presence or absence of a given feature in the EHR, and that presence or absence is also allowed to vary as a function of the underlying true phenotype status. So for instance, R might represent whether or not the patient has their glucose measured, and the probability of having your glucose measured is going to differ depending on whether or not you have the underlying condition of diabetes. We're going to do estimation in a Bayesian paradigm, and so we're going to assign priors to all of these model parameters. And this was a really important piece of the model because this is an unsupervised learning approach. So this is going to be difficult to estimate all of the parameters in this model without injecting some additional external information. And specifically, the way that we're going to do this is to use informative priors that are informed by the clinical knowledge base about coding practices and about differences in these characteristics between patients with and without the condition of interest. For instance, if the feature that we're talking about is a biomarker, a shift in the mean of that biomarker might be known based on prior validation studies of that assay and clinical knowledge about how the distribution of that biomarker differs between people with and without the condition of interest. So we'll take our set of observable features, we'll take our priors for the model parameters informed by the clinical knowledge base. We put those two things together, and that will allow us to obtain posteriors for theta I, that patient-specific probability of having a phenotype. And in fact, in this setting, rather than focusing on yi, that unobservable latent characteristic of the patient, we're going to use the posterior for theta I as a measure of the patient's phenotype. So their posterior probability of having the condition of interest, given all of the things that we observe in the EHR, is going to become the phenotype that we use in subsequent analyses. I'm going to illustrate this approach using data from the PedsNet Consortium, which is a consortium of pediatric healthcare systems that was funded by PCORI. In this example, I've put together a data set using data from just 2 of the pediatric healthcare systems in PedsNet, and I specified inclusion criteria in order to try to have a set of children who were at increased risk for type 2 diabetes. So specifically, we're going to focus on kids who are aged 10 to 18 who have at least 2 clinical counters in the study time period that were separated by at least 3 years. So we wanted to have some minimum depth of information for these children. We also required that on at least one occasion, they had to have a BMI Z-score in excess of the 95th percentile for their age and sex, so that we're really focusing on a high-risk subgroup. When we applied these inclusion and exclusion criteria, we ended up with a cohort that consisted of about 30,000 kids from Site A and 24,000 kids from Site B. This table illustrates the distribution of some of the features that are going to be incorporated into our phenotyping. So at Site A and B, we can take a look at the mean and the standard deviation of biomarkers and of various binary features, like whether or not the child was ever prescribed a medication used to treat type 2 diabetes, whether they ever made a visit to an endocrinologist, diagnosis codes, and importantly, whether or not their glucose and hemoglobin A1C were ever measured. The thing I think is interesting about these distributions is that they reflect the fact that practice patterns differ between the 2 sites, in addition to the underlying prevalence of the condition. So for instance, we see that at Site B, glucose is on average a bit higher and hemoglobin A1C is a little bit higher. But we also see big differences in the way that these patients are interacting with the healthcare system. So at Site B, 19% of kids had ever made a visit to an endocrinologist, 6% had been prescribed metformin, and 2.8% had been prescribed insulin. And in comparison, all of those proportions are much lower at Site A. We also see big differences in the way that type 1 diabetes and type 2 diabetes codes are being used. And we see differences in the frequency with which glucose and A1C are being ascertained. As you'll notice, these are very frequently missing. So a large proportion of kids have no glucose measures. The majority of kids at both sites have no hemoglobin A1C. And you see that at Site B, glucose is more likely to be missing compared to Site A. And at Site A, hemoglobin A1C is more likely to be missing compared to at Site B. So I think it's very likely that there is a true difference in prevalence of the condition between these 2 sites, but there's also just lots of differences in the way that the kids are interacting with the healthcare system, the codes that are being used, the medications that are being prescribed. And all of that is important to take in mind or to keep in mind when we're doing phenotyping, because every healthcare system is different. Practice patterns are different everywhere. Patient populations are different everywhere. And that really means that within each healthcare system, we need to have a phenotyping algorithm that works in that system. This is an issue called lack of portability or lack of transportability, that often phenotypes that perform well in one site don't perform well at another, just because these differences in the EHR and the differences in patients across locations. We applied our phenotyping algorithm separately to kids from site A and kids from site B, and this is an example of some of the parameter estimates that we get out of that model. So here I'm showing posterior means and 95% credible intervals for some of the parameters in our model. For instance, we were able to estimate the mean difference in glucose between patients with and without type 2 diabetes. We estimate a sensitivity and a specificity for every binary feature that appears in the model. And the ones that I've highlighted here in bold red are ones that differ pretty substantially between the two sites. So for instance, at site A, the posterior mean specificity for making an endocrinologist visit is 94%, whereas at site B, it's only 84%. And if you remember back to the previous slide, at site B, we had many more kids making an endocrinologist visit compared to site A. So it makes sense if we were to use that single feature all alone to try to distinguish kids with and without type 2 diabetes at site B, we would probably end up with poorer specificity. The last thing that I want to highlight on this slide is that we're also able to estimate an odds ratio associated with having your biomarkers measured. So here we see that if you have your biomarkers measured, you're at much higher, no, sorry, I put that backwards. If you have type 2 diabetes, you have much higher odds of having your glucose measured compared to a child who does not have type 2 diabetes. And that was true at both sites, although at site B, the effect was even more marked. So at site B, children with diabetes have odds that are 5 times higher of having their glucose measured compared to kids without diabetes. And that's important to recognize because that really reinforces the fact that there's a connection between the underlying condition that we're trying to study and the types of information that are going to be available in the EHR. And finally, for each child in the data set, we come up with a posterior mean probability of having type 2 diabetes. And this is the distribution of those posterior means at the two sites. You can see that those posterior means separate into two peaks, and that's a good thing because here we're essentially looking at a mixture distribution where we're mixing over those two latent classes with or without the phenotype of interest. So the peak with higher probabilities represent the kids who had some data elements indicative of having type 2 diabetes, and that lower peak represents kids who had data elements pretty exclusively indicative of not having type 2 diabetes. We also see that in general, the distribution at site B is shifted to the right just a little bit compared to the distribution at site A, representing that increased prevalence at site B relative to site A. As an overview of some of the points that I've touched on and things that I would hope that you take away from this part of my presentation, firstly is just this idea that the information that's available in the EHR is heterogeneous. And if we're going to conduct research with this data, we have to have adequate data capture for all of the key data elements that are necessary for our research. Most importantly, though, it needs to be systematic data capture. We don't want to have a different depth of information available for different patients. And if we do, or to the extent that we do have a different depth of information available, or lack of systematic capture, we need to account for that in our analyses by explicitly incorporating aspects of data provenance process. The accuracy of our phenotypes is going to be fundamentally dependent on data provenance and the provenance of the constituent data elements, so we need to account for that in our analyses. And in particular, there's a risk of differential misclassification if we fail to do so, because a clinical decision rule that ignores that heterogeneity across patients may not perform equally well for all individuals. And then finally, just going back to the difference that I had emphasized between site A and site B, transportability of phenotypes may be limited due to heterogeneity of practice patterns and patient populations. So data provenance and the issues that it generates for phenotyping is an important first step to consider in EHR-based research. But ultimately, we will have generated a set of phenotypes, sometimes for our outcomes, sometimes for inclusion criteria, sometimes for exposures. And ultimately, we're going to take all of those phenotypes that we have created to characterize our patient population, and then we want to use them to answer some kind of interesting question. So the next part of my talk is going to focus on how we overcome information bias that arises due to the fact that we're now using imperfect EHR-derived phenotypes to try to make inference about relationships between treatments or patient characteristics and outcomes. One of the most concerning things that I observed during the pandemic, when people started to get really excited about doing research with EHR data, was a notion which I remember seeing someone specifically tweet about, that if you have enough data, you don't need to worry about the data quality. They essentially said, if we use EHR data, we have so many millions of people in our data set, how can we possibly get the wrong answer? And what I would say is that is completely backwards. If you have a large enough data set and that data set is error prone, you're almost guaranteed to get the wrong answer. So in EHR-based research, we know that we have many sources of bias, as I mentioned earlier. We also have big databases. So there are EHR databases out there that cover millions and even hundreds of millions of patients, which means we can generate estimates that are extremely precise. So on the right-hand side of this slide, I have a cross-classification of bias and variance. And in the EHR setting, if we don't do anything to attend to the sources of bias, we potentially find ourselves in this lower right-hand quadrant where we have high bias and low variance, which is, to my mind, the most problematic setting, because it means we think that we are very certain about our estimate, and our estimate is completely wrong. So I would say that in these big data sets, we have a substantial responsibility to do as much as we can to reduce bias in order to make sure that that estimate that we can come up with very precisely is actually on target and providing information about the parameter that we care about. So given all of the messiness, given all of these sources of bias, the fact that we're using imperfect EHR-derived phenotypes, what can we do? There are some specific challenges in the EHR setting that we're going to have to make sure that we're attending to and that constrain our options a little bit. We're dealing with a setting where we have error in our data elements, and often a way to deal with that would be to use validation data. In the context of an EHR setting, validation data usually means conducting a manual chart review, having a human look at medical records and make a gold standard determination as to whether or not the patient has the condition of interest. That's an expensive process, so most EHR-based studies at best do a small validation sub-study. It's also slow. And depending on the type of EHR claims-based data set that we're working with, it might be impossible. So if we're using a completely de-identified data set, or if we're using a claims data set that we've gotten from an insurer where all of the identifiers have been stripped off, then we obviously have no ability to go back to the source records and obtain gold standard phenotypes for anyone. So at best, we're going to have a small amount of validation data. Additionally, there's the problem of transportability that I mentioned earlier. So operating characteristics may vary substantially between the derivation data set and other data sets. And then the fact that we have this heterogeneity in the information available across patients, providers, and healthcare systems leads to a high risk of differential error across our patients. So given all of those challenges, the context that I'm going to focus on is one where we would like to make inference on the relationship between a vector of patient characteristics X and a binary outcome Y. And I'm going to assume that we're in some sort of a generalized linear model type of a framework. The specific application that I'm going to use to motivate this part of my talk is that of trying to estimate the occurrence of second breast cancers in women with a personal history of breast cancer. So our outcome of interest here, Y, is a second breast cancer event, or SBCE. And we would like to relate that to patient characteristics such as the patient's age, the stage at diagnosis of their first breast cancer, and the hormone receptor status of their first breast cancer. So those patient characteristics X are related to outcome Y according to a vector of parameters beta. However, because we're doing this in an EHR context, we don't observe Y. Instead, we come up with some kind of SBCE phenotype. So this is an imperfect surrogate for Y that we've been able to extract from the EHR based on some kind of phenotyping algorithm. And for this part of my talk, I'm assuming that the phenotyping algorithm exists and that it gives us a binary classification as to whether or not the patient has the condition of interest. So I'm thinking of something like one of the clinical decision rules that I mentioned earlier in my talk. We additionally may have information about the relationship between Y and S. So here I've given the sensitivity of S and the specificity of S, and I've indexed them both by X to represent the fact that we think that the accuracy of our phenotype is going to differ according to characteristics of the patient. So try to incorporate that differential misclassification piece. I'm going to compare 4 different approaches to trying to make inference about data. The first approach, model 1, is a conservative approach, which we would take if we conducted a validation substudy in a subset of the patients. And for that subset, we come up with the true outcome Y. So in model 1, the subscript V denotes the fact that estimation is only going to be focusing on our validation subset. We're going to regress Y on X. We're going to come up with consistent estimates for our parameter interest beta, and I'm going to denote those estimates beta hat V. This is a conservative approach because we're using gold standard information on the outcome, but we're doing it in just a small subset of our data set. So we have this small subset, we're going to get a consistent estimate, but it's going to be an imprecise estimate. In contrast, if we are very enthusiastic about EHR-based research and we think we have a good phenotype and we trust it and we want to kind of go all in on that phenotype, we could take our surrogate S and regress that on X to get estimates of beta star. So beta star is that parameter relating S to X, which differs from beta in some way that we don't quite know since we don't know the relationship between S and Y. So in model 2, we're putting a lot of faith in S. The subscript F here represents the fact that estimation is going to take place in the full data set. And because we're using the full data set, we're going to come up with a very precise estimate. So this is our low variance estimate, but we don't know whether or not it's consistent for beta. So we're just sort of hoping that we have a good enough phenotype. An alternative would be to use an existing approach to outcome misclassification. So here I've cited a paper by Magder and Hughes, which was published 25 years ago and gives us the maximum likelihood-based solution to this problem. It says if we know the structure of the misclassification model that relates S to Y, we can make a maximum likelihood-based adjustment to our estimate, and we can come up with the actual maximum likelihood estimator for beta, which incorporates information about the misclassification in S. The limitation of this approach is that it does require that we know the structure of the misclassification model, and we have to correctly specify that misclassification model. In the results that I'm going to show coming up in a few slides, I've assumed non-differential misclassification. So I've assumed that the sensitivity and specificity of S are the same for everyone. Model 3 does not actually require that we assume non-differential misclassification. It just assumes that we do know the structure of this misclassification model. So it could be that it's conditional on age, or it's conditional on hormone receptor status, but we have to know that, we have to be correct about it, and we have to correctly specify the functional form relating that characteristic to the misclassification. I'm going to show you results from a fourth approach, which I'm going to call augmented estimation, which is a data adaptive approach developed by a student at the University of Pennsylvania, Jesse Tong. It was published in Journal of the American Medical Informatics Association a few years ago. The idea behind this approach was to deal with the problem of phenotyping error or outcome misclassification in EHR-based studies using a data adaptive approach that would account for some of the features that we expect to see in an EHR setting. So what this approach does is essentially to say beta hat V and beta hat star F are two different extreme approaches to using the information that we have at hand. So depending on how good our phenotype is, we could put more information, we could put more weight on beta hat star F. And so what we would like to do is create a weighted combination of these two things that capitalizes on the consistency of beta hat V and the low variance of beta hat star F. One of the features of this approach that makes it really nice for EHR-based studies is that it accommodates both differential and non-differential misclassification. It does not require explicit specification of the misclassification model. In order to use this approach, we're going to define one additional regression, which is to regress S on X in the validation subset only. We then construct the augmented estimator by creating this weighted combination of the three estimates, beta hat V, beta hat star V, so that's that estimate using the surrogate as the outcome, but in the validation subset only, and beta hat star F. The weights here, omega hat and sigma hat inverse, are essentially a correlation matrix, and that correlation matrix is telling us about how close beta hat V is to beta hat star V. So when we look at our estimates based on the validation sample only, if our estimate in the validation sample using the true outcome looks very much like our estimate in the validation sample using the surrogate, then that would suggest that the surrogate is quite good, and we could just go ahead and put a lot of weight on beta hat star F. On the other hand, if the correlation is low, then that suggests our surrogate is not very good, and we better do the conservative thing and put all of the weight on beta hat V. So this correlation matrix here in the center of the equation is going to vary between an identity matrix, which would represent, let's put all of the weight on beta hat star F, and a matrix of zeros, which would say, let's put all the weight on beta hat V. So here I'm comparing the performance of these four different approaches using a data set that had three different surrogate outcomes. So in the real data set that this is based on, we actually had second breast cancer event gold standard status assessed for every woman. So if we were to use that gold standard information for everyone, we would come up with a point estimate, which is represented here by the dotted black line, and its confidence interval is given by the shaded gray band. What I'm showing in the three figures is if we pretend that we don't have that validation information available for everyone, and instead have validation sample sizes of varying size from 400 up to 1200, how does each of our four methods perform, and how does that performance vary as the accuracy and the misclassification structure of our surrogate varies? So here on the left, where I have the high specificity surrogate, I'm showing results for a surrogate that is highly accurate. In the center, the non-differential surrogate is a surrogate that is less accurate, but the accuracy is non-differential across individuals. And then on the right, I'm showing results for a surrogate that is differential, that is rather poor, and where the accuracy is differential, so it differs across individuals. The results in red represent that validation data only strategy. So they're going to look the same across the three different surrogates because we're ignoring the information from the surrogate. You can see that when the validation sample size is small, as expected, the precision in that estimate is poor. The precision gets better as the estimate gets larger, as the validation sample gets larger, and the estimate is consistent, so it's going to move towards the truth. It's going to be closer to what we would have gotten if we'd had the true outcome status for everyone as the validation sample size gets larger. Model 2, which only uses the information on the surrogate but does it in the full sample, will look the same regardless of the size of the validation sample, because in Model 2, we're throwing out the validation information and just focusing on the surrogate in the full sample. We see that it produces an estimate that's very precise, and when our surrogate is accurate, we get something that looks very close to what we would have gotten if we had the true outcome for everyone. In the center, when we have a non-differential surrogate, but that surrogate doesn't have very good accuracy, now focusing just on the surrogate does not work so well. We've got an estimate that diverges from what we would have gotten using the truth quite substantially. And the same is also true when we have a differential surrogate. Approach 3, making a maximum likelihood-based outcome misclassification correction, works well and gives us a pretty precise estimate when we are able to correctly specify the misclassification model. So here across all three settings, we've assumed non-differential misclassification. So in the first two, the high specificity surrogate and the non-differential surrogate, we've correctly specified the misclassification model. Model 3 performs quite well. On the right-hand side, when we have a differential surrogate, and so we have erroneously assumed non-differential misclassification, making that maximum likelihood-based correction performs poorly, and in fact exacerbates bias relative to not having made a correction at all. So that's definitely a caveat about that approach. We have to be pretty confident that we really do know the structure of the misclassification. And then finally, model 4, the augmented estimation approach, represents a trade-off between these different approaches. So in general, its precision is going to lie in between model 1 and model 2 because it's a weighted combination of those two things. It performs well across most of the settings that we looked at. It doesn't matter if the misclassification is non-differential or differential. However, one caveat of using this approach is when the validation sample size is small and the structure of the misclassification is complex, it tends to perform poorly. So in that small validation differential outcome misclassification setting, we saw poor performance. So I believe strongly that there's no free lunch. There's no one approach that's the right answer to everything. I think the augmented estimation approach is a really clever idea that works great in many EHR contexts, but it does require a pretty substantial amount of validation data. So just to sum up from the second part of my talk, the methods that we use in analyzing EHR data really need to acknowledge the presence of measurement error and misclassification because they're ubiquitous. There's almost nothing that we observe in EHR data that's really completely true and accurate. Appropriately considering these sources of information bias is really key to obtaining valid inference, making valid conclusions using this data source. And as I said early in my talk, when you raise the issue of data quality with people, it's often not top of mind in terms of things that they want to worry about as a source of bias. I think confounding gets a lot more attention as a source of bias than information bias, but they both equally threaten the validity of our results. So I encourage the researchers that I work with to undertake methods that account for measurement error and misclassification, or at least conduct sensitivity analyses to investigate robustness of their findings to these types of challenges, and not just to relegate this to the sentence in the limitation that says, there might have been outcome misclassification in our study, but we think it was probably non-differential, so it probably biased results towards the null, but we don't really know, and everything is probably okay, don't worry about it. It really deserves more attention than that, given the precision of the estimates that we're able to obtain, and therefore the weight that people end up attaching to them. The last part of my talk is going to focus on the issue of equity in decisions that we make using risk models developed in EHR data. So increasingly, as we have access to healthcare data that are generated almost in real time, people are interested in using this information for the purpose of personalized medicine so that we can make recommendations for the treatments, the interventions, the screenings that patients receive that are tailored to their individual characteristics and their individual risk of a predicted response or risk of disease. Much of my research has been conducted in the context of cancer screening. So in the setting of cancer screening, when we talk about personalized medicine, what we're really talking about is personalized screening or risk-based screening. So what we would like to do is develop risk models that predict the patient's probability of experiencing cancer or their probability of experiencing a particular harm or benefit associated with screening, and then tailor the screening recommendations for an individual patient to those predicted risks. Using EHR-derived risk prediction models to conduct this kind of risk-guided screening or risk-guided medical decision-making has equity implications because of the potential differential performance of these models for patients with different racial and ethnic backgrounds. So for instance, patients of underrepresented race and ethnicity don't contribute as many observations to the development data sets that have been used to generate these risk prediction models, and therefore the accuracy in those underrepresented patients may also be poorer. Many of these models incorporate polygenic risk scores, which were developed in populations of European ancestry. So when the patient that we're applying those models to is not of European ancestry, the model is not going to perform as well. And most importantly, from my perspective, kind of focusing on data quality, the data that we're using were generated by a medical system that has all sorts of historical patterns of inequitable care and outcomes, and has differentially more fragmented, more barriers to access, more challenges to creating the pieces of information that arise in the EHR data that we need to make the prediction for patients who are medically underserved. So for all of these reasons, there's the potential that when we start to move into this era of personalized medicine and personalized screening, we may be perpetuating patterns of inequity because our risk models don't perform as well for underserved patients, for racial and ethnic minority patients, as they do for majority patients. I'm going to show you an example of the implications of using EHR data for this kind of risk-guided screening, based on a study that I participated in with researchers from the Breast Cancer Surveillance Consortium. So in the Breast Cancer Surveillance Consortium, we were interested in coming up with a risk prediction model for what we're going to call surveillance failure. So surveillance failure represents a second breast cancer event, so a second breast cancer in a woman with a personal history of breast cancer that was missed by a routine surveillance mammogram. The rationale for this model was that if a woman has a high risk of having her cancer missed by a mammogram, then that's someone who we would want to recommend receive more frequent surveillance or receive surveillance with an alternative modality like MRI in order to try to avoid that negative outcome. We looked at the overall performance of this model, and then we also looked at performance across race and ethnicity subgroups. And the thing that I really want to emphasize here is that coming up with this kind of prediction model has policy implications, because it means that individuals who have high predicted risk are potentially going to get access to advanced surveillance modalities that individuals with low predicted risk are not. So if we look at our data and we're systematically making predictions that are either less accurate or more likely to be high risk predictions or low risk predictions for some race and ethnicity groups compared to others, then that implies that those groups are going to have less access to advanced imaging modalities than other groups. So in our study, we looked at a variety of different risk prediction models. We compared an expert model where our clinician colleagues just specified the variables that went into the model. We looked at a variety of different regularized regression approaches, and we looked at several machine learning approaches. And in this figure, I'm showing you the calibration of those models overall. This is the expected to observed case ratio, the calibration intercept, and the calibration slope. But the important thing here is just that the gray line is the target, and to the extent that the estimate deviates from that target, we're looking at a model that has poor calibration. So for the models that were well calibrated in this overall population, we then asked the question, are they well calibrated within race and ethnicity subgroups? In this figure, I've taken those same models and I'm now looking at the calibration, the same calibration metrics for 3 race and ethnicity groups. One thing that you'll notice in this figure is that we're only looking at calibration for Asian Pacific Islander, Black, and white women. We had to exclude women of Hispanic ethnicity as well as those of other races from this evaluation because the sample sizes were too small to come up with estimates that were meaningfully precise. So right off the bat, we're not even able to conduct the investigation for some of the subgroups that we might be interested in. However, by and large, when we look within these subgroups at calibration, we see poor calibration according to some metrics for some groups, but in general, these align pretty well with the results from the previous slide where we looked at the overall population. So the models that were calibrated well in the overall population tend to also be calibrated well within these subgroups. That's reassuring, but it's not the end of the story because the data that we're using here are EHR-based data. They're the same EHR data that we use to generate the model. And so if those data are systematically more likely to be misclassifying the outcome or misclassifying predictors for some groups compared to others, then when we look at calibration using a data source that has the same structure, we're going to come to the conclusion that everything looks just fine, when in fact we're systematically making errors that we don't know about. In order to investigate the implications of using EHR-derived data to develop a risk model and then deploy that model in order to guide supplemental imaging recommendations, we conducted a simulation study which investigated the implications of the structural set of relationships describing how race and ethnicity affects downstream outcomes and how that would impact the performance of our risk-guided surveillance. In the figure at the bottom here, I'm illustrating the sets of relationships that we assumed in our simulation model. So we assume that race and ethnicity does not directly affect second cancer risk, nor does it directly affect mammography performance. However, it does indirectly affect those through two things, mediated by social determinants of health, as well as characteristics of the primary tumor and its treatment. So the parameters in this model that describe relationships between all of these different types of variables were estimated using real data from the Breast Cancer Surveillance Consortium. We then simulated data which reflected those distributions, but in which we eliminated some of the sets of relationships in order to come up with a simulated data set in which we essentially blocked the effect of race and ethnicity, which was mediated by either social determinants of health or primary tumor and treatment characteristics. The idea behind this investigation was to take a look at how a risk-guided surveillance strategy performed across race and ethnicity subgroups, and then to see how much any observed differences in performance were attributable either to the relationship between race and ethnicity and social determinants of health, or the relationship between race and ethnicity and primary tumor and treatment characteristics. Finally, we additionally allowed ascertainment of second cancers to vary according to race and ethnicity. So that was reflecting the fact that we felt there might be differential data quality across race and ethnicity groups. We then applied to the simulated data a risk prediction model where we predicted either the probability of experiencing a surveillance failure or the probability of experiencing a second cancer, and then made supplemental imaging allocation decisions based on that predicted risk. And ultimately, what we wanted to see was in these different simulated data sets, which either included or excluded some of these structural relationships between race and various downstream variables, how different would our supplemental imaging allocation recommendations be when we used these different risk prediction models? Importantly, the prediction models that we created do not explicitly include race and ethnicity, but they do include social determinants of health, and they do include primary tumor and treatment characteristics. So we'll take a look at the setting where we eliminate the relationship between race and social determinants of health, a case where we eliminate the relationship between race and primary tumor and treatment characteristics, and then also a case where we eliminate both of those sets of relationships, and we essentially assume that all of the data arise from a common distribution for all patients without reflecting any differences across race and ethnicity. So this first slide is showing how risk-guided supplemental imaging recommendations vary across race and ethnicity subgroups when we make those recommendations based on the probability of a surveillance failure. So when we simulate the data in such a way that cancer is allowed to vary across race and ethnicity groups, so those primary tumor and treatment characteristics, we see that Black women are recommended for supplemental imaging at a much higher rate than other groups. And when we additionally allow social determinants of health to vary across groups, we see an even higher probability that Black women are recommended for supplemental imaging. When we additionally introduced variation in ascertainment of second cancers, the results were very similar to what we saw in that previous case. And that was because the differences in data quality that we introduced were not that severe. They were motivated by a prior study looking at completeness of ascertainment of second cancers by race and ethnicity. But in this setting, they appeared to play a relatively small role. However, what's going on here is that supplemental imaging recommendations are being largely driven by the fact that Black women were more likely to experience a surveillance failure in our predicted risk model because there was a really strong connection between educational attainment and the probability of experiencing surveillance failure. So if we were to look at these results and take away from this that Black women should all go out and get MRIs because mammography doesn't work as well for them, that would really be a naive and incorrect way of interpreting these results, when in fact what we need to be saying is there are structural failures in our healthcare system. We need to make sure that women of lower educational attainment are receiving mammograms at facilities that perform as well as facilities that are serving women of higher educational attainment. Quite contrastingly, if we used a model that based our supplemental imaging allocation decisions on predicted second cancer risk, when only primary tumor and treatment characteristics vary by race, we see that a lower proportion of Asian Pacific Islander and Hispanic women are recommended to receive supplemental imaging. Similar results occur when we additionally allow social determinants of health to vary by race and ethnicity, and when data quality varies by race and ethnicity. So this is a setting where results are being driven by biological differences in the tumors that are experienced by these groups. And in this case, we might say, although these models perform in a way that leads to differences across races, we might consider this not to represent an inequity because the differences in supplemental imaging allocation reflect differences in biological characteristics of the tumor. So the conclusion here is even when we use risk models that don't include race, because of all of the complex structures that are encoded in the healthcare data that we're using, there's still going to be differences in the decision-making that results from those models across race groups. This has been very broadly investigated in the algorithmic fairness literature. But in this context, we have to ask ourselves, what does it mean for a model to be fair? There are many different metrics that we might use to evaluate these models. And what we really need to be thinking about is what are the downstream outcomes associated with using one risk-guided strategy versus another. If we were to use the strategy that says women at high risk of surveillance failure should receive supplemental imaging versus the model that says women at high risk of a second cancer should receive supplemental imaging, do those lead to equitable outcomes across different race and ethnicity groups? I think that piece of kind of closing the loop and thinking about how these models impact outcomes as opposed to just how their accuracy or how their calibration differs across race and ethnicity groups is really important next step as we start to think more precisely about fairness implications of personalized medicine. And additionally, in the example that I just showed you, data quality didn't play a very big role in the results that we found. But ultimately, we need metrics that account for the fact that we're using imperfect data to build these models, and we're using imperfect data to evaluate these models. So we really need to incorporate the fact that we know that our outcomes are misclassified into the evaluation of their fairness. Just to wrap up, I hope that I have emphasized in my talk today that EHR data have a lot of potential. There are many things we can do with them. They allow us to answer questions more rapidly than we might be able to using clinical trials or longitudinal observational studies, and also to generalize the evidence that we generate to a broader population, to everybody who's receiving medical care, instead of just people who are able to participate in clinical trials or willing to participate in longitudinal studies that perhaps span decades. This gives us the opportunity to look at populations that have been historically underrepresented in medical research, but we need to be thoughtful when we do that and think about the fact that those populations are also potentially underrepresented in healthcare data. There are many methodological challenges, so there are tons of open questions. There are tons of future research studies on methodology that we can conduct because there are so many imperfections in these data, missing data, measurement error, error in confounders, and on and on. And in general, when we're doing EHR-based analyses, these problems tend not to exist in isolation. So I've focused on phenotypes and phenotyping error, but in fact, we're often in settings where we have phenotyping error, as well as missing data, as well as selection bias, and we really need to be thinking about all of those things simultaneously. And in particular, almost all of these problems tend to be differential because of differential data quality and the complexity of data provenance. So we need to be cognizant of the fact that the methods that we choose should account for that differential data quality. One of the things that I love about working in this context is that I feel it's an ideal setting for data science because it really demands a multidisciplinary perspective. We have to bring together experts in informatics who know how to handle the data and how to deal with big data sets and where they come from and how these things are encoded. We need engineers who can work with those big data sets, who can offer advanced machine learning techniques. I think statistics also plays a really key role because of our understanding of study design, of how to make valid inference. And the domain expertise piece is also key. It's very easy to do very naive, very poorly informed research with these data sets. And I think we have an ethical imperative to make sure that we're using data from real healthcare encounters, from real people, to answer the most important questions that we can in the most valid way that we can. So I will just end on that note of ethical implications and imperatives. It's important to remember that we're using healthcare-derived data. So these data were created through a system that encodes various societal biases and historical biases. And we need to think about whether or not the methods that we're using and the research that we're conducting is at risk of perpetuating those inequities and those biases. We need to think about who's represented in the data set and why, and whether or not access barriers like insurance status affect the quality of the data that we have for some individuals, or their ability to access the system and therefore generate the data that we're using to conduct research. And then, as I emphasized in the last part of my talk, we need to think about the downstream implications of the research that we're doing and the models that we're building and how it impacts policy decisions and real people's access to medical interventions. I also strongly believe that as scientists, we have an ethical obligation to do the most rigorous research that we possibly can. I think we owe it to the evidence base and to the scientific record to be trying to get the answers as right as we can, as good as we possibly can, as close to the truth as we possibly can. And so on the right-hand side of the slide, I have a panel from an XKCD comic. In this comic, they illustrate various different kinds of error. I assume we're all familiar with type 1 error and type 2 error, but in XKCD, they posited many other kinds of errors that we could make. And I, in particular, like to draw attention to type 7 error, incorrect result, which produces a cool graph. As humans, we love things that are new and shiny and flashy, and we always want to be innovating and taking the next step. But we need to make sure that when we do that, we're not just doing it because it looks cool and exciting, but that it actually means something and is really helping us to advance science. So I will end there. Thank you all for your attention. I want to say thank you once again to the Washington Statistical Society for the Gertrude Cox Award. I'm very honored, and I'm honored to have had your attention. Thank you.